Hi and welcome. I'm Dr. Robert Glatter, Medical Advisor from Medscape Emergency Medicine. Joining me today to discuss the outcomes of distal femoral versus tibial versus proximal humeral intraosseous catheter placement and non-traumatic out-of-hospital cardiac arrest in adults is Dr. Peter Antevy, Pediatric Emergency Physician and Medical Director of Coral Springs Parkland Fire Department in Palm Beach County, Florida. Also joining me is Dr. David Miramontes, Assistant Clinical Professor of Emergency Medicine at University of Texas Health Science Center in San Antonio. He's also serving as the Medical Director for the City of San Antonio Fire Department. I want to welcome both of you to this discussion about intraosseous needle placement, site-specific, how it matters, where it matters, especially in the setting of out-of-hospital cardiac arrest. Peter, I'd like to begin with you to start things off. Really describe your experience in the setting of cardiac arrest out of hospital. You have a patient in extremis. How do you approach this patient? And we can talk about shockable versus non-shockable rhythms.
Awesome. Well, Rob, thanks for having me. The setting of cardiac arrest in the out-of-hospital setting is very important. It's a very choreographed event. And so obviously we go through our progression. And so let's just focus on access at this point in time. Rather than messing around and looking for an IV, et cetera, we have made it a protocol that we go right to IO access, intraosseous access. And that has been something that we know we can get, we know where to go, we know how long it's going to take. And I can really take a stopwatch. And from the moment we say go, I know when that IO is going to be. And that's how kind of exact we are with our timing. And it's really faster than we can put an IV in.
Okay. And David, your experience, same thing or anything you approach that differently?
Yeah. So for us, we've been doing the IO portion of this part of our cardiac arrest management for some time. And one of the big reasons, logistics, location. So we have a bunch of people at the head of the bed in cardiac arrest. We have 2 people doing airway. We have someone doing compressions. We have someone that is starting to put the monitor on. So that's a lot of people at the head of the bed. So what we've decided is that logistically, it makes sense to use the distal femur as our med port because it's on the other side of the patient and everybody's out of the way. And that works really well for us. Now, if you can get that good anticubal IV, great. That's what you should use. But if you can't get it on the first click, you should go right to IO if that's not even the first thing you should do. In my system, my EMTs do IOs, okay? So a lot of times, the first arriving engine has already got the iGel in, they've already defibrillated, and they've already got the IO in place. And if there is a medic on there, they'll start the medication therapy right from the engine or the truck. And then when the medics get there from the ambulance, they continue with the rest of the protocol. So for us, the IO is all about location. It's out of the way of our choreographed pit crew style care.
Does the rhythm matter, whether there's a shockable versus non-shockable rhythm in your approach, site-specific? And I'll ask you, Peter, first.
Yeah, that's a great question. So years ago at the NAMSP, during the oral abstracts, Dr. Modaya presented some data that when I first heard it, I didn't believe a word of it, which was that if you give amiodarone or lidocaine through an IO, then the outcomes are worse than if you would have given it through the IV. So I let that kind of sink in a little bit, didn't really change much practice. And then his paper came out in 2021. And then I read it and I said, okay, still, I want to see more. And then another paper came out in 2023, which said the same exact thing. And Rob, I have to admit that based on what I've seen there, and we can discuss the data if you'd like, but I've now modified my protocol so that if it's a shockable rhythm, that it's preferable. I don't make it mandatory, but it's preferable to get an IV over an IO. We can discuss the reasons for that physiologically, at least the one that I've made up in my mind as to how to explain the physiology. But yes, I've made that change.
Okay. And David, is that your approach currently, or would you differ?
Kind of. So we have a little different way of dealing with shockable rhythms. So if it's a BPEP-BTAC, we have a shock call go protocol where we take them to an ECMO center. And so we're not giving any meds Yes, I said that. We are not giving any meds, no epi, unless they don't have a pulse with Lucas CPR. We're not giving amiodarone because a lot of times we shock them to a systole, and then the guys at the hospital won't put them on pump and they won't go into the program. So if we're going to give any kind of medications, it's bicarb. That's to kind of work the protocol so their pH is above 7 so they can go on pump. Right now, we are using the femoral IO most of the time. The data that we're going to be talking about is rather compelling to rethink that. And, as Peter said, the amiodarone lidocaine, it may have to do with the lipophilicity of the drug, and it doesn't get through the fatty bone marrow. We don't know. But I think there's a signal. I don't know that it's absolute, but it's concerning that we should probably rethink what we're doing.
Absolutely. And so in the setting of refractory VFib, pulseless VTAC, in those situations, you shock them multiple times, nothing's happening, you're going to the ECMO center.
So it's shock, call the medical director, go. So it's very quick. So after one shock from anyone, we're doing basic airway skills loading and getting going to the ECMO center. And then the meds, like I said, really are not really helping us, to be honest with you. In fact, they're probably hurting us. And so the epinephrine, we know from the Paramedic 2 trial, actually causes probably worsening ischemia in the brain. The amiodarone is not going to work if the patient's in recurrent VFib or VTAC because their left main's clogged. So until you open up that vessel, we're not going to have a good outcome.
People who are listening today need to understand that a lot of the recommendations that are put out in ACLS, they're based on, for example, the epinephrine is based on puppies. I'm back in the 1960s, 1970s. And so a lot of the things that we do today really don't have a basis in science. So a lot of things that you hear Dave is doing, we've also removed epinephrine from our shockable rhythm protocol, and our outcomes are phenomenal. We've added esmolol. We use double sequential for the refractory cases. So I think what you've seen in the last, let's say, 5 to 10 years, is that in EMS, there are many people doing different things. But I think as long as you're following the science, you're actually monitoring your outcomes, and then publishing what you do, I think that's really the right way to go. But I don't see an RCT coming anytime soon to answer many of these questions. So that's the fascinating part about this whole thing.
In terms of getting patients to ECMO centers, where you're located in Palm Beach, how does that pan out?
Yeah. So I'm also down here in Broward County, and ECMO is for the very specific type of patient, right? The reason that I'm sure Dave has the call the doctor aspect of it is because if it's not an ECMO type patient with age, with respect to were they witnessed or not, what was their no flow time, ultimately they need a lactate level. There's all these characteristics. You end up having a small number of people. So in each area, you're not going to have tons of ECMO centers. You probably have one. So we do have that. We have one ECMO center here in Broward County, and we have several saves. We have a guy named Gary, 55-year-old guy, refractory VF, and Memorial Hospital saved this guy's life with ECMO. But those are very few and far between. And so I think that communities will have to see, is the juice worth the squeeze? But if your hospital is already an ECMO center, they have ECMO for all the other things. The question is, can they do ECMO in the emergency department 24/7? Are they going to bring you those resources when you need them in the middle of the night? And if the answer is yes, then, if a patient's in VF and in refractory VF, you should go there quickly. So I would agree with David on that wholeheartedly.
Right. If we talk about anatomic landmarks and ease of placement of proximal humeral versus a distal femoral IO, where do you feel is, again, a more like a skill that can be acquired more easily? Do you find that the humerus people are more afraid of based on the anatomy, or do they prefer, say, the distal femur? What are you finding in your systems? David, I'll let you go.
Yeah, so again, for us, it's logistics. So the distal femur, as long as you keep the legs straight, you're good to go. And most of the time when you're moving a patient, they're going to be on a backboard or a stretcher or something and the leg's going to stay straight. So we're good. Now the humerus, on the other hand, you look at me, I got my arms up on the Lucas, and what's sticking out? You got sticking out that big old humeral yellow easy IO. And all you have to do is touch it once and it's done, right? So that's a huge issue if you're moving patients. It doesn't stay in very well. Yeah, they have the holder, and that holder does not work if you whack it on the way taking a patient out of a hallway, for example. Okay, and so that's one of the issues with the humerus. Is the humerus harder to put in? I mean, if you teach them really well, you have a cadaver lab, that it's not that bad. I think the distal femur is even easier, especially in kids. But I think that it's all about logistics in our world. And do I use the humerus? All the time. I use it in sepsis patients. I use it all the time in awake patients. I think that's a great place to go. But for us in cardiac arrest, it's the femur.
But if you're looking at studies, maybe they're animal studies, some human studies, looking at IVC versus SVC in terms of where you're putting the catheter. For example, the proximal humerus versus a distal site, distal femur. In terms of the IVC versus SVC and getting the patient, in other words, getting the medicine where it needs to be, there is a difference. Would you not disagree?
I would totally agree. Getting it, we know that meds given in the humerus get to the central circulation much quicker. We can see this in the lab. I mean, you flow that, and that's a plague vein, just balloons out. That is true. But you have to balance that with logistics and patient movement and those types of factors. That's why I'm a big proximal humerus guy for sepsis and for other types of medical cases. That works. And let's not forget about trauma. So if you've got trauma below the nipple line, you should not be doing a femoral IO, right? You should be in the humerus, right? So there's advantages and disadvantages to both sites, and you have to weigh the pluses and minuses of both.
Right. So I guess in small critical access hospitals where, a fair number of transfers come, I think, for ease of transport, really going distal femur makes sense, again, based on the location, if there is trauma or if it's a medical case. Would you not both agree on that, just for, in other words, for long transport times?
I would agree.
Yeah, and just to put a pin on the pediatric side, because David mentioned it, David's group did a great study on the distal femur IO in adults, and everybody should read that study. And what I found fascinating about his study is that once they allowed the distal femur, you saw all the paramedics kind of shift over to that. And that's without an arm twist. That's because they knew it was, like he said, it was logistics. It was easier to do, and they liked it better. In children, for many years, people used a proximal tibia. And there was a data back in 2019 out of resuscitation that showed that 47% of the proximal tibial IOs were malpositioned in infants. 39% were malpositioned if you were greater than a year, so the children. That's a very high number. And when you look at the distal femur IO, it's so easy to place. The cortex is thicker. When that needle gets into that cortex, it's not coming out. Unlike what David said, the other ones, you can just kind of flick them and they come out. So I'm happy to say that we just actually submitted and was accepted our paper for pre-hospital emergency care, where we have the first paper on the distal femur IO in pediatrics with a 90% success rate. Once our crews do it once, they're never going back. And so for pediatrics, I think it's a no-brainer, and people should abandon the proximal tibia completely, in my opinion. But in adults, I think now you have options. Proximal humerus, distal femur, those are both great options.
Is there any issue with growth plates in pediatrics, or any issue with bone, the cortex, in terms of resilience after that you're seeing years later? Any follow-up to that?
The common teaching is that you want to stay away from the growth plate. It's much easier to hit the growth plate when you're going proximal tibia. And that's why they kind of want you to angle away from the growth plate. When you're going with the distal femur, Rob, if you just look at a photo of the anatomy, if you're a centimeter or two above the patella at the midline and you hit that bone, you're very far from the growth plate. Unless you kind of angle inferiorly and you are kind of aiming towards the growth plate, you're going to hit it. But I would say that, much safer. I've never seen a follow-up study on the IO gone wrong in children, but I'm sure there are cases of it, but it's never been reported to my knowledge.
How about David? Have you seen any problems at all in your population with placement? Any kind of complications with intraosseous catheter placement?
I'm just going to reiterate then that the proximal tib is not a good place. And if you get it wrong, you're going to cause a compartment syndrome in that lower leg. So that's a problem. Okay. Now, if you get it wrong in the femoral space, there's way more room if you've infused fluid or meds in that fascial space, then you will not have a compartment syndrome there. I mean, you'd have to angle underneath the patella to get into the femoral growth plate. I just don't see that happening, especially if the leg is extended. The patella rides up, so it basically covers up where the place you don't want to be.
Exactly. This is great. I really appreciate your time. Listen, any pearls that each of you have, just to kind of summarize and wrap up, maybe one or two pearls from each of you?
So I was going to say that if you're in a rural ER and you're having problems with access, you shouldn't even flinch. You should just go ahead and establish access. And if you're going to give fluids and pressors and get the patient better, chances are you're going to pop up a great vein in the brachial vein or an acubital space later after the resuscitation is started. Now you have two lines, right? Or you could put one of the rapid infusion catheters in the brachial space or something like that. So I wouldn't even flinch using an IO. Now, I think the distal femur is great. I think there's questions about using that spot with certain drugs like amiodarone and lidocaine. The data is pointing in a direction there, and as a signal, and it makes me pause and think. And I'm glad Peter has flipped away from that. But when said and done, the best thing is a good large bore IV in a vein. If that's not available, just drill them.
What I would add on is, for the pediatric cases, some very important information here is that easy IO needle, again, I have no conflict, it's just the one that we use. But the reason it got a patent so many years ago is because it's a cutting needle. When you look at the edge of that needle, it's like a knife, right? It's like knives. If you have a newborn, a 1-month-old, a 2-month-old, you should not use the drill. Whether you're going to choose the femur, the distal femur, or the proximal tibia, just use your hand, because the bone is so soft. I've seen people use the drill and they just go right through that bone. So in the very young infant, use your hand. Second pearl is that everybody says, wait, this distal femur thing is great. How do I train on it? And I've been in contact with 2 specific people for years and with Teleflex to try and get a distal femur trainer. Well, I'm happy to say that it's finally available. Both people have kind of come out with them at the same time, and we finally got our hands on 10 of them, and we absolutely love them. So I think that if you're going to go distal femur, finally now you can get access to a trainer so that you can train on it and then convert your entire agency away from the proximal tibia. And then lastly, I'll say that there's a rumor that they're now going to get a 65 millimeter. So, the 25 is the blue, the 45 is the yellow, which is the largest we've had. But Dave has been using the distal femur on these adults for a long time, and he needs a bigger one. So apparently there's a 65 green coming out. Dave, I don't know if you know about that. They're probably going to give it to you first.
So for our bariatric patient, we actually do cut down IOs. So what we do is we cut down through skin, we cut down through fat to the fascial plane, and then we drill. But if you've got that problem, that's an option. And now apparently we're going to have a bariatric needle available for them.
Well, it's about time. I think, that's a real challenge. Many patients I've had, same thing. The needle just isn't long enough, and then you're having a very difficult time getting access. So I think that's very, very important.
Dave is selling himself short. He's got probably the most premier EMS system in the country. Always interesting to hear what he's doing in Texas.
Yeah, and I also want to mention that you're both members of EAGLE's, Dr. Pepe's premier pre-hospital and resuscitation expert panel. And listen, I appreciate your time. This is really such an important topic, because getting to access in critically ill patients really matters. It's time, it's organ preservation, as you all know. Okay. Thank you so much for your expertise here.